Good morning, ladies and coronavirus germs. This is your Ticker Guy update for the 27th. I'm going to lead with a piece of the press conference yesterday afternoon. And Dr. Birx, who finally comes around to the truth and stops with the bullshit. I want you to listen to this. It's about 2.5 minutes. And then immediately following that, we'll be right back with me.
I'm sure many of you saw the recent report out of the UK about them adjusting completely their needs. This is really quite important. If you remember, that was the report that said there would be 500,000 deaths in the UK and 2.2 million deaths in the United States. They've adjusted that number in the UK to 20,000. So 500,000 to 20,000. We're looking into this in great detail to understand that adjustment. I'm going to say something that's a little bit complicated, but I'm going to try to do it in a way that we can all understand it together. In the model, either you have to have a large group of people who are asymptomatic, who've never presented for any test, in order to have the kind of numbers that were predicted. To get to 60 million people infected, or 6 million people infected, you have to have a large group of asymptomatics, because in no country to date have we seen an attack rate over 1 in 1,000. So either we're only measuring the tip of the iceberg of the symptomatic cases, and underneath it are a large group of people. So we're working very hard to get that antibody test, because that's a good way to figure out who are all these people under here and do they exist. Or we have the transmission completely wrong. So these are the things we're looking at, because the predictions of the models don't match the reality on the ground in either China, South Korea, or Italy. We are about 5 times the size of Italy. So if we were Italy and you did all those divisions, Italy should have close to 400,000 deaths. They're not close to achieving that. So these are the kinds of things we're trying to understand. Models are models. We're adapting now to the reality. There's enough data now of the real experience with the coronavirus on the ground to really make these predictions much more sound. So when people start talking about 20% of a population getting infected, it's very scary. But we don't have data that matches that based on the experience. And then,
okay, so what did we learn from this? What I've been saying for the last 2 months? Diamond Princess, ladies and gentlemen, said that the attack rate and the infection models and the epidemiological bell curve, which is what everyone uses, and look, it makes sense because it's what diseases historically do. It's a very sound mathematical fact. If you look at mathematics, it's, you learn exponents in school, folks, and if you graph them, they all look the same way. All those models said that certain things were going to happen. And then we had a petri dish that was that cruise ship. And yet we had couples in the same cabin, and if you've ever been on a cruise, you know what the size of a cruise ship cabin looks like. They were quarantined in their cabins. They in a couple of, at least one very well documented case, husband and wife in a cabin. One of them gets very sick. The other one does not get sick at all. And yet they were cooped up for days and days and days and days together in the cabin. Now, I think it's fair to assume that it was impossible for them to avoid close personal contact during that entire time. It's impossible. Secondly, they're husband and wife. You would expect the one who is well to give care to the extent of their ability to the one who is sick. That's what husband and wives do, right? So we had that. We had a bunch of people who tested and were negative. We had a bunch of people who tested positive and never got ill. And some of them later went on to develop symptoms, but not all. And a huge percentage of the people who were on that ship got off the ship, went into 14 or 21-day quarantines, were essentially held for that period of time, and neither turned positive nor did they get sick. Okay, now, there's several problems with the model at this point, because we now know that the distribution point, and we knew this shortly after the ship was evacuated and they started going through it, and the people that were on it, including the service staff, we know that the distribution point for the virus within this ship was, in fact, the people in the galley. Now, that's not surprising. In fact, that's how essentially all the noroviruses and stuff get going and keep getting seeded in cruise ships. Cruise ships are fantastic for this kind of thing, and it isn't helped by the fact that we have essentially a bunch of third world crap eaters that work on those ships. That's their business model. They hire people from those places because they can get them for $5 a day. And if you tried to hire Americans that were weaned and taught that from the first time you take off a diaper, that your feces goes in the potty, you keep your damn hands off of it, you flush it, and then you're supposed to go to the sink and immediately wash your hands with soap and water. These people all come from countries where that's not the norm. Now, you can teach them, and they do, okay, and there are protocols, and there are, but if you go into any restaurant anywhere, in America or anywhere else, and you actually think that hand-washing sink gets used the way it's supposed to, you're out of your effing mind. It doesn't. Well, it didn't here. And yet the people who got it on the ship had a normal distribution. In other words, it wasn't one cabin steward that was assigned to deal with one specific floor or piece of a floor on the boat. The people that got sick were all over the place. All right. So the social distancing meme people will all tell, well, this is proof that the lockdown. No, it's not proof the lockdown worked. In fact, it's proof that even if you had herd immunity, it didn't make a damn bit of difference if you were one of the remaining susceptible individuals, because the virus was being directly transported to your door on your food tray. And if you think that it survived going through the dishwasher, you're crazy. It did not. Okay. So that's step one. All right. Then we had this model that the report yesterday morning was that it was revised. And now all of a sudden it says 50,000 people in the UK may die. Instead of a crazy number, or 20,000 instead of 500,000. And all of a sudden, oops, the 2.2 million number gets revised out too. All right. Now, the problem with this is that this doesn't make any sense either. All right. Unless this guy says, except, hey, wait a minute, that other number is awfully close to the kind of numbers I was coming up with originally, looking at the Diamond Princess, looking at South Korea, looking at Japan, looking at Singapore, looking at Italy. All right. And again, and also, by the way, looking at Miami and Broward counties, Dade and Broward counties in Florida. Now, here's the other thing that's interesting. All right, so those cases now in Florida are starting to rise rapidly. Well, wait a minute. We locked down almost 2 weeks ago now. So why are they still rising rapidly? Well, because those social distancing and shutdowns, they don't do anything. And why don't they do anything? And remember, folks, all restaurants closed, okay, except for takeout and delivery. Bars are all closed, all right? It's not a lockdown in the strict sense, but it's close enough. The beaches have all been closed. And here we are, okay? Now, I want you to contemplate some things, though, that go along with this. All right, so the distancing protocols and the things that are being put out, they're not stopping it. All right, neither are the lockdowns. All right, so what Birx is saying is that our model's wrong. Well, your model is wrong, doctor, and I've been saying that for the last 2 months. Your models are not only wrong, they're catastrophically wrong. Now, let me point out some other catastrophically wrong predictions as well. There's another one that's flying around the net from a group of people that are trying to scare the ever-loving blankety blank out of everyone. Bunch of people on there, oh boy, they can program a computer and produce pretty little graphs. Well, guess what? I can do that too. But you know why I haven't done it? Because it's not worth doing, and I'll explain the reason why. I'll just give you one example. They have a state, they have what the status is of each of these states, and then why you must act now. All right. And this says, note, this model is intended to help make fast decisions, not predict the future. Oh, but but wait a minute. If you're trying to make fast decisions, you should be predicting the future, right? That's the point of making fast decisions with incomplete data, is that you are trying to make a prediction about the future. So let me tell you what their predictions are. If we do what social distancing, social distancing and essentially close to a shelter in place, okay, closing essentially all non-essential businesses, which is pretty close to where they are at this point in Florida. It's not completely there. Okay, I can still go to the hardware store, I can still go to the grocery store, but all the social kinds of places are all locked down. They're closed. They've been closed now for the last 2 weeks, essentially. They've been soft closed for 2 weeks and hard closed for the last week. All right, so this is enough time to get into the data sets, because remember, the turn time on the data sets is about 4 to 5 days. In other words, if all the people who have it, 4 to 5 days is when they, in that window, is when they infect the next group of people. All right, and we know, and the data on that is consistent, folks. All right, so here's the thing. If you were to Wuhan-style lockdown, okay, you end up with a cumulative percent of less than 1% infected. If you have 3 months of shelter in place, you have a 2% cumulative infective. If you do anything less than that, you end up with 70% cumulative infected. Okay, and then the dire scenario, the estimated dates when hospitals were overloaded, and then, of course, the scare number, the one at the end that scares the living hell out of everybody. 300 to 400,000 people dead in the state of Florida. All right, now let's go through the fallacies and why these people not only should they not be believed and acted upon now, but every one of them needs to be remembered, their bios and who they are taken down, printed out somewhere. You need to research all of the places they work, every one of the businesses that they control and have a controlling interest in or are employed by, because it will come time for them to pay for this scaremongering. The time is not now, folks, but the time will come when this doesn't prove up. Now, if I'm wrong and it does prove up, well, I guess you can come after me. But if it doesn't, then they must pay for this. And frankly, I've changed my mind about an awful lot of things. I don't care really so much how that pay happens. I would hope it's peaceful and lawful. We'll leave it at that. Why do I say, though, that this is fantasyland bullshit? First off, the 3 months of shelter in place, estimated date, hospitals overloaded, and next to, right under there, guess what it is? Outside time bound. All right, do you know what that means? That means that they stopped counting it. All right, so 3 months is their time frame. Okay, they go out to July. What happens when you drop the shelter in place? Well, you have 2% of the population is cumulatively infected, but you get no herd immunity until you get to 70. You get no effect on herd transmission until you get to about 35. So what we are really saying here is that we're going to go ahead and suppress this for 3 months, and then as soon as we drop it, it's going to come back. Why? Because unless you kill every last carrier of the virus, either inside the country or from outside, in other words, every one of those people runs to resolution. Either they die or they recover. As soon as you drop the constraints, the exponential curve reasserts itself. This is math. All right? You can't. It's not going to be otherwise. All right. So let's think about the next thing. All right. So they say that with 2% infected, we're going to get 5,000 deaths in Florida. 5,000 dead over 3 months in Florida. In Florida, folks. Okay? Not across all 50 states. In one state. And if you don't do it, you're going to get 300,000 to 400,000. In other words, almost 100 times greater. Now remember, the argument is that 2% are infected, 70% are infected if you don't do it, 2% are infected if you do. So there's 35 times as many people, okay? 35 times as many people get infected, but we're going to have 5,000 dead if we do these things, right? And 35 times that would be 175,000 people who die. All right, first off, that's fanciful. All right, the 2% and 5,000 is fanciful. It's absolutely fanciful. Do you know how many people are dead in Florida right now across the entire state? 35. 35, folks. How many people are dead right now? All right, and every one of them is terrible, but how many people are dead right now in New York? Let's look at that. There are 385 people who have expired. 385. Now, New York is getting slammed, all right, but 385 people have expired. The catastrophic constraints just have not occurred. although they were all predicted. Now, here's the other thing that's interesting. This site has, boy, oh boy, do I wish I'd screenshot a couple of these. They've changed the doom dates for a couple of states. All right, there were a couple that I noted that had doom dates that were in the past a few days ago. And now all of a sudden the doom date's out in the future. Well, wait a minute. How's that possible? If you're past the doom date, then no matter what you do, it doesn't make any difference. Doom's going to happen. But the doom isn't going now. The doom's in the future again. How convenient. Isn't this like global warming? I think it is. We had a model. The model said this was going to happen. The model said that I would have waves lapping at my back porch right now. Okay. Well, okay, not quite that far. I mean, the prediction was for, 10 foot of sea level rise in another 80 or 90 years. And so on a linear basis, I should have had a foot or two. Right? A couple of feet by now. Well, guess what, folks? I've had a dock here out my back door for 20 years. All right? And I know exactly where the water line is in the winter and the summer, and I know what the tidal range is, too. We have a relatively small tidal range. There's been no change in where the water is. Maybe an inch. That's about all. An inch. 1 inch. Okay? And oh, by the way, for those of you that think that this is a one-off, there's another amusing anecdote that goes with this too. In the 1970s, the Great Lakes area, specifically the lower Great Lakes, between near the entrance to Lake Erie and the Detroit River, had a number of years of extraordinarily high water levels, flooded people's homes. There was a very expensive house, somewhat near where I lived, that had been built without proper permits. They never could have gotten a permit. It was built essentially as on a piece of the Dock H piers, okay, hanging right over the water. Beautiful place, and very expensive. The people that owned it were rich SOBs. I don't know exactly how they got away with putting that up, but they did. And then the water level rose, and they had 1.5 feet of water in their living room for a year and a half. Oops. Well, that ended up abandoned and ultimately torn down. But and I suspect their insurance wasn't any good either. But so I mean, Mother Nature is just a mother. We'll just leave it at that. So anyway, I want to go back and use some CDC data and tell you why all these scaremongering things are clowned. Okay, including this thing. There was the guy that had the original crazy prediction for the UK clowned himself, because then he comes out on Twitter and says, "Oh no, I really didn't revise the model. That was if they implement these lockdowns, and if they don't, then the disaster's still got." All right, folks, this is CDC data. It's current as of probably yesterday. I just looked it up before I recorded this. The CDC says that 12% of the people who come in and get coronavirus tests and test positive, okay, end up needing hospitalization. Now, let's look at the total number here. All right, we're going to look at the total number of tests. We have, as of right now, as I record this, we have 82,000 positives out of 540,000 tests. All right, so we've done 500,000 tests, and we've had about 82,000 positives, which means that about 15% of the people who are sick enough to get tested, and remember, the protocol here is that if you don't have a fever and you're not showing obvious symptoms, or you cannot document some kind of connection to an existing case, you don't get tested. All right, so we are only testing people who appear to have coronavirus on first blush. You look at the people who have coronavirus, think they have it, they come in, they get a swab stuck up their nose, and 15% of the time they're right and they have coronavirus. All right. The other 458,000 people do not have coronavirus. They've got something else. Or they have it and the test is wrong. Now that's important, okay? Because 30% of those tests false negative. In other words, you have it 30% of the time, you have the virus, you take the test, you don't come up positive for it. Now, this was considered an acceptable error rate by the CDC. Frankly, I think that's insane, but that's where we are, okay? The math is what it is, all right? So, out of these positives, the CDC says that 12% of the people who are positive will need a hospital. In other words, they qualify for admission to the hospital, 12%. All right. Now, that's just the people who test positive. So we have 15% of the people who have a flu-like illness and actually show up and try to get tested. All right. You've got obvious symptoms. Of those, 12% of the 15% need any kind of hospital bed at all. Okay? So we got 12% of 15% is now 2% of the people who have flu-like symptoms. All right? Now stay with me because it gets even better. And only about a quarter of those, 20% of those, end up needing actual hospital intensive services. In other words, things you can't do outside of a hospital. That would be an ICU bed. Okay, ICUs are where you get intensive monitoring. You got the EKG hooked up. You got a machine that's taking your blood pressure, your temperature on a repeated, on an all the time basis. And potentially, you may have a vent shoved up your either down your throat or on a positive pressure mask. All right, so. And by the way, once that vent goes down your throat, there's all kinds of other problems because obviously you can't eat or drink anymore. So now we have to provide all of your nutrition and all of your fluids through IVs. All right, there's no other way to do it because you can't eat with a tube down your throat. And so, those are last ditch kinds of things. All right. But the important thing here, folks, is that's 0.5% of the people who have a positive test, and this is before we've corrected for the false positives. All right, 0.5% end up in the ICU. All right, now, as it turns out, we have 330 million Americans in this country, roughly, and we've tested 540,000 of them, and these are the numbers. All right. So 0.5% of those who are symptomatic enough to get a test. We also know from Wuhan that if you end up on a vent, that 95% of the time you go home in a box. Now that sucks. Now I'm going to make an assumption. Okay? And that is we're better than they are. I don't know that that's true. I haven't been able to come up with any data on resolution percentages for intubated patients in coronavirus in the United States. Nobody's publishing it. But I will tell you this, the data from before coronavirus is very bad. In general, if you're intubated, 50% of the time you never make it out of the hospital. Okay, these are facts, folks. Listen, I don't like them. I think they're shit, but they are what they are. 50% of the time, leaving aside a virus that's attacking your lungs, you don't get out of the hospital. And 70% of the time, you don't make it 1 year past discharge. Okay? Now, I don't know about you, but just getting out of the hospital for me is not good enough. I think a 1 year survival rate is that's probably not all that bad, right? I mean, it's probably a reasonable definition of success, but only 30% of the people this virus make it that far. And this data is from 2015, folks. It's current, okay? This is best of our medical technology that we have today. So the data out of Wuhan says 95% failure rate. I will give us another 5. The reason is I don't think it's as good as 70. That would be insane to believe that we fail 70% of the time. I will say we're better than the Mr. Slanty Eyes that broils cats for dinner. And so as a result, it's not 95% of the time that we fail. We fail somewhere between 80 and 90%. Pick your number, doesn't really make any difference. Now, what this means is that if there is an overload in the hospital, the outcome is only going to change for 10% of 0.5% of the cases that currently meet the testing criteria. Folks, this is a vanishingly small number. All right. Now, with 330 million Americans and a 70% attack rate before we get to herd immunity, that's an awful lot of cases. All right. But when you start running these vanishingly small numbers over the course of this outbreak, what you run up against across the entire American population And there's a decent range on this because a lot of it depends on exactly how successful you are with rescues in the hospital. All right, and that is a big unknown right now. Nobody's publishing that data, so I've got a range. I've got a boundary range. And the worst case scenario that I'm using is that we are twice as successful as Wuhan, which may be optimistic, but I'll go ahead and I'll take that. All right, that we are twice as successful as Wuhan. So the range that I come up with in American deaths when I take all these numbers and I crunch them is that if we have hospital overloads, in other words, you don't get a bed when you need one, all right, it is going to put another 15 to 20,000 on the low end to maybe 40 to 50 on the high end. And again, depends on our success rate on the deaths over what you would have if we didn't overload the hospitals. In other words, everybody who needs a bed gets one. Everyone who needs a vent gets one. There are no unfilled needs. And the difference in outcomes is about 20,000 dead people. Now, how many people die anyway? Well, that ends up, best case calculation, if there are no overloads, it's about 50,000. And if there are overloads, it probably ends up being about 60 to 70,000. For some perspective, a reasonably bad flu season in the United States kills 60,000 people a year. The one that we're in right now, CDC estimate, I think, is 40 or 45. We're kind of up the middle, sort of, between a light one and a really awful one. So, Wu flu, if we did absolutely nothing and just let it rip through the population, the excess deaths that would be caused by lack of facilities would be measurable. Be about 20,000 individuals that would die that we could otherwise save, but we would have done zero damage to the economy. If we lock everything down and we leave it locked down and you succeed, you'd say, well, it'd be worth it because the 20,000 deaths would be avoided, except that's not how it works. You don't avoid them, you defer them, because as soon as you release the constraints, the herd immunity is not there and the spike happens anyway. The scare scenario was that we were going to start from a base of 2 million deaths in the United States, and that is fanciful. It hasn't been borne out by any of the data from anywhere. None of the data supports that prognostication. Absolutely none. And you say, well, look at Italy. Okay, I will look at Italy. Italy has a very bad outbreak right now. They have 6,800 people that have died. But to put perspective on this, an awful lot of people die in Italy every year anyway. And how many of those deaths were actually caused by the virus? Well, there have been some folks that have gone and taken a look at that, and they've said, how many of those deaths, when you actually go through them and you look at the data, you actually look at the death certificates. You don't just take, okay, someone died and they had a positive test, but you look at the death certificate and figure out, was this actually plausibly caused by coronavirus? Okay, plausibly caused. In other words, it's a pneumonia death in somebody that otherwise didn't have pneumonia. All right, that would be a coronavirus death. All right, because the virus attacks lungs. It's not somebody who has a heart attack and you take them in there and posthumously hey, he's positive for corona. Come on, guys. That's not a coronavirus death, okay? Or he has diabetes and he has renal failure, and he goes into the hospital, and because he's admitted to the hospital, they test him for coronavirus, and he's positive. Well, the coronavirus isn't the reason you had renal failure, okay? Most of these people are people that had long-standing comorbidities. They found 12% where you could reasonably attribute the death to the actual coronavirus. So how many people in Italy do you think have died as a direct result of coronavirus? The answer is 818. Now, 818 is still 818 people that I wish weren't dead. But it's 818 people, folks. It's not a catastrophe. It is not a world-ending number. Now, do we have the same pattern here in the United States? I don't know. because as far as I know, nobody's actually gone through coroner certificates yet and death certificates and looked at what the acute cause of the person expiring is. But assuming that that's the case, we currently have, current data is 1,197 deaths. If 12% of them are from coronavirus, we had 143 people expire. So let's say that we are 10% of the way through, or even 5% of the way through the deaths in the United States. We've had 1,200 people basically have kicked it. And let's further say, which we know is not true, that every one of those is a legitimate coronavirus death. And we know that's not true. Well, then we're going to have about 20 or 30,000 people fall over dead as a result of coronavirus. That's very sad, ladies and gentlemen. It really is. Every one of those is terrible. Right? It's not, I mean, this is not a, it's not a contest. It's not, all right. And now let's see. I just see an update here on my screen. Okay, so now another 900 people in Italy have expired. Okay, well, again, sad, but how many of those people actually died of, not with coronavirus? Well, what we saw before was about 12%. And you know what? Maybe it's going to be more when we get down to it, when we get down with this. Maybe, we end up with 20 or 30,000 people that expire from this thing from coronavirus in the United States. Am I going to be surprised by that number? No, I'm not going to be surprised by that number. But the important point is not how many people die from coronavirus in the United States. The important point is how much of a difference will it make if we take these measures and we do these things that all the scolds are telling us and have been telling us to do. And the answer is it will make very little difference, if any at all. If you have look, folks, if the reality is that when you go into ICU and you get a tube down your throat, most of the time you die anyway, then not having a bed in the ICU doesn't change what happens. The goal has to be, and here's the other thing we're not controlling for, which is a really bad problem. How many of those people that go into those hospitals acquire another infection, a bacterial pneumonia or something like that, while they're in there? And by the way, intubation is a great way to, oh boy, is that a great way to give somebody something. The absolute last time that you need to have another infection is, when you're already trying to fight one, right? That happens all the time. We kill 100,000 Americans that way every year, and we're going to kill some percentage of the people that go into the hospital and end up in the ICU with something they get in the ICU. Now, I don't know exactly how many of those people we're going to kill, but we're going to kill some of them. The goal must be to keep people out of the damn hospitals. Okay? It has to be, folks. It's the only thing that makes any sense. That will actually bend the curve. The reality is that if I can only change the outcome of 10% of the cases with hospitalization, and that's what it looks like, okay? Because remember, anything else, being able to monitor your oxygen saturation, Pulse O2, you can buy one of those things that clips on your finger that costs $10. All right? Oxygen in a bottle with a bleed valve set from 0 to 15 liters per minute. We have those are available. Regulator's about $30. The tubing and the nasal cannula, which you can insert yourself, it's not a medical procedure. It's a piece of vinyl tube, for Christ's sakes. It just kind of sits in the entrance to your nose. Supplemental oxygen. We can send patients home with those. We can give them a pulse ox. We can tell them, look, as long as you are able to get up and move around the house and go to the bathroom, things like this, without becoming winded, and your pulse ox is over 95%, as long as those two things are both true, you do not need to use the supplemental oxygen. If either one of those things is false, then we start monitoring you very aggressively. And we do this through telemedicine. We do it through remote reporting and give people the hydroxychloroquine and azithromycin. Yeah, let's use the drug protocols. Are they going to work for everybody? No. And for those people who are contraindicated, well, you don't get it. But if it is indicated, let's use it. Why? Because we want to keep people out of the damned hospitals. Why do we want to keep people out of the hospitals? Number one, it prevents overloads. And number two, but far more importantly, because the overload isn't going to kill as many people as people think. Okay? I mean, let's face it, folks. The reality is that if you go into the hospital, you're probably about as likely to be killed by an infection you get in the hospital as you are to be saved with this bug. I wish that wasn't true, but it is true. All right, that's how I suspect the balance of harms and benefits balances out. When you get into a situation where 90% of the people that end up with a tube down their throat die, you're talking about a 1 in 10 chance of being saved. If you also have a 1 in 10 chance of picking up another infection in the hospital during those invasive procedures, well, guess what? All of a sudden, you haven't changed outcomes a bit. You kill 10% of the people you give the procedure to, and 90% of the people die anyway. Well, it seems to me that if you only save 10%, you kill 10%, that's a zero. All right, now are the numbers that bad on one side? I don't know, but what I do know is that the odds suck just being intubated generally. So how can we possibly, folks, you need to think of this critically, okay? You need to put critical thinking to this. How can you save 1,000 times more people, 1,000, when your starting base is 12% of tested flu-like symptoms, and only a quarter of that 12%, plus deflated, by the way, by the positives you missed? All right, so the real number is closer to 9. Only a quarter of those actually need to go into a hospital care only setting. So we are now down to the point that we are, of all of the positives, it's a fraction of a percent. And out of that, and this is out of the people who are actually positive, we end up with a couple of percent of the people who are serious enough that they meet admission criteria. All right, 2-3% of those people end up in an ICU. And of those people, we can't help 90% of them. We spend all the resource and we don't get a return on it. The patient dies. How the percentage of people you save is 10% of those who go into the ICU. You can't get 1,000 to 1-fold change in death rate from that starting statistic. You can't even get a 10-fold change in death rate starting from that statistic. You can get a 10% change in death rate. So if the hospital overloads, 50,000 people die. If the hospitals don't overload, 45,000 people die. We're going to destroy the entire U.S. economy over that delta, because that's the delta. Those are the maximum numbers, folks. I know people don't want to hear this, but it's the truth. And I don't know what the base number is, but if I can only make a 5% change in outcome, then all of this nonsense and arm waving is stupid. And if you think that suppressing the transmission rate is going to change the total number of cases, you're wrong. What you're hoping for, what you're dreaming for, is a vaccine. And I will leave you with this when it comes to vaccines. All right, because everybody is doing this. Listen, we've had this before. This has been run by these very same people in these pharmaceutical companies in the past. And we need to start holding them to account for this. People's heads need to roll here, folks, because we did this with AIDS. All right, there's going to be a vaccine. There's going to be a vaccine. There's going to be a vaccine. Most of you are not old enough to remember this or listening to this podcast. I am. I remember it for years. There'll be a vaccine soon. We're starting trials with this. We're doing trials with that. We got this. We got that. None of them have ever worked. We are how many years down the road now at this point? Almost 40? There are coronaviruses that infect animals. We've been trying to come up with persistent antibody vaccines that actually provide permanent immunity in animal husbandry for a very long time. We haven't succeeded. And we've also never managed to come up with a coronavirus vaccine for humans, for any other coronavirus that has provided persistent immunity either. So we have failed to do it with this class of viruses in animals, and we failed to do it with this class of viruses in humans. I've been looking for a single piece of evidence that a persistent animal husbandry coronavirus vaccine in animal husbandry has been developed and is given to animals as a prophylaxis, basically like you do for polio. I haven't been able to find one. Not one. Maybe it exists. If it does, I'd love to know where it is, because that would actually provide some hope. But when you have an unbroken list of failure to get on the television and say, we're going to get this. No, you're not. I mean, listen, you might find a unicorn that craps out pretty colored candies, but the odds are against you. You're almost certainly not going to get it. It's almost certainly not going to happen. And so all these scaremongering websites and projections are a load of bunk. They are all predicated on trying to change an outcome because you have medical care. They are all predicated on this false belief in the population that hospitals are places where Marcus Welby and House inhabit. And nobody ever dies. As long as you get into the hospital, you never die. That's just not true. The data out of Wuhan says it's not true. The data out of our own ICU says it's not true. And that's with things that don't attack the lungs. There's no evidence to support such a position. It's crazy. So this idea that you're somehow going to get exponential level differences in death rates, whether we have hospital overloads or not, is just not the case. It's just not, folks. And the idea that we are somehow going to prevent people from getting this thing is also false. The only way you're going to prevent transmission permanently, okay, not avoid it today and get it tomorrow, but actually prevent it, is if we were to manage to kill off all the reservoirs of this thing. The last human case is extinguished. There are no more animal reservoirs, and it never comes back. And that the odds of us managing to do that on a worldwide basis are essentially zero. The only other thing we can do is we can defer it, but at what economic cost? And that's the question that needs to be asked. We need to be adults about this, folks. All right? We all run the risk every year that we're going to get the flu or we're going to get a cold. And if you're old and frail, it might kill you. That could happen. If you're just plain old-fashioned frail, it could kill you. That might happen. If you're a cancer patient, oh boy, you really have to be careful because the chemotherapy destroys your immune system. All right? So, I mean, there's things we can do that are logical. We can reduce transmission rates. We can reduce risk. For people at high risk, they can stay home. They can self-isolate. They can throw everybody in the household that isn't willing to do it with them or isn't seropositive out. We can test for seropositive status so that if you are going to be a caregiver for an elderly person that is at risk, you know that you can't give it to them because you can't carry it and you can't get it yourself. These are all things we can do. These are all logical steps. We can quarantine people who are positive and show up at a healthcare center. Not in their own house, unless everybody in the house is willing to quarantine, but in somewhere else, in a hotel, in a somewhere, okay? I don't care where it is. You can do a sanitarium-style model if you want. Most of these cases resolve within 2 weeks. Does it suck to be hit with a quarantine order for 2 weeks? Well, yeah, it does. But hit the people who actually are positive with the quarantine order. Everybody else goes on with their lives. Anyone that is positive, seroconverted, if you're not sick right now, you're not going to get sick. You're safe to wander around, do whatever the hell you want. Lock the borders to those people who can't demonstrate seropositive status. If you're not a U.S. citizen, that's the way it goes. If you are a U.S. citizen, you can come in. However, if you're not seropositive, you're going to do 2 weeks in quarantine. That's just the way it goes. Same thing with people coming across the border in trucks or whatever have you. You can't demonstrate you're seropositive. You drop the trailer. Somebody else picks it up who is in the United States, and he takes it because we can't have people coming across the border seeding infections. And we keep doing this until we either get herd immunity or effective sets of drugs, none of which we have right now. All right? The hydroxychloroquine, it works in some people. It doesn't work in others. We don't know exactly what the number is. We don't know how effective it is, but we know it is somewhat effective. We know anecdotally it's very effective. And in addition, if you look at the rates of transmission of COVID-19 in places that have chronic malaria problems, you will see a stunning difference in case transmission between those nations and the ones that don't have malaria. Well, what's the difference? In the places that have chronic malaria transmission, guess what? An awful lot of people are taking prophylaxis for malaria. And it seems to be inhibiting COVID-19 transmission. Is that totally effective? Well, I don't know. There's no clinical trial. There's no scientific proof for that. But what does the evidence tell us at this point in time? It says maybe it does. These things need to be examined. But at the same time, we cannot destroy the economy, folks. All right? No, numbers are numbers. This guy, with his study, the one that scared everybody and set this all off, he's clowned himself now. He did it twice. First, he essentially retracted it. Then he came back and said, oh, no, I didn't. And yet, when you looked at his claim, it was risible to the point that you thought this guy's Wile E. Coyote, super genius, filling up carrots with nitroglycerin on a train track. When I saw that last night, I literally broke out in laughter. I couldn't believe it. Let's use our heads, folks. I'm your ticker guy, and that's how it is.